Welcome to The Explainer. Today, we're focusing on one of the most remarkable, yet honestly frequently overlooked structures inside your body, the kidneys. These organs are absolutely the body's unsung heroes. They work tirelessly, totally behind the scenes, to keep our internal environment perfectly balanced. In this explainer, we're going to break down exactly how this incredible filtration system works, what actually happens when it begins to fail, and how modern medicine fights back.
All right, let's dive into this with a number that might actually surprise you a bit. 10 to 14%. That is the estimated percentage of the population currently suffering from chronic kidney disease. So we're not talking about a rare, isolated condition here. It is a widespread, systemic issue that literally impacts millions of us. Understanding how to protect this system really starts with understanding exactly what's at stake.
So, here is our roadmap for today. We'll start with number 1, the kidneys as our unsung heroes. Then 2, acute versus chronic failure. Followed by 3, understanding chronic kidney disease. For number 4, we'll look at the systemic domino effect. 5 is diagnosis and detection. And finally, 6, fighting back with treatments.
Okay, let's jump right into section 1, the kidneys, unsung heroes.
Before we can even talk about failure, we really have to establish the baseline of normal function. And the sheer scope of what your kidneys actually do every single day is mind-blowing. Nestled near your lower back, they don't just make urine, right? Yes, they absolutely filter metabolic wastes, fluids, and electrolytes from your blood, but they also stimulate red blood cell production. And they play a massive role in regulating your overall blood pressure. They are ultimate master multitaskers.
Let's zoom in, way into the microscopic level to see how they pull that off. The structural unit of the kidney is the renal lobe, but the functional unit, the real star of the show here, is the nephron. Initial blood filtration happens in the renal corpuscle. Specifically, this happens in this tiny spherical network of capillaries called the glomerulus, which is enclosed by a cup-shaped structure known as Bowman's capsule. Basically, pressure forces the filtrate right into this capsule, and as it passes through the renal tubule, an incredible 99% of that glomerular filtrate is actually reabsorbed back into the body. Only the true waste is eliminated. It is ridiculously efficient.
Moving on to section 2, acute versus chronic failure. So what happens when this delicate, microscopic architecture breaks down? Well, there are two very different clinical situations here. First, acute renal failure. This is sudden, short-term, and typically it's reversible. It's often caused by things like a sudden hemorrhage reducing blood flow, certain toxins, or even just a physical urinary tract obstruction, like a kidney stone. Chronic renal failure, on the flip side, is the loss of kidney function over a period of years. The underlying cause is sustained, and that leads to progressive fibrosis, serious scarring, and basically irreversible dysfunction of those delicate renal structures.
Which brings us to section 3, understanding chronic kidney disease.
Medically speaking, chronic kidney disease, or CKD, is characterized by reduced kidney function or damage that's been present for more than 3 months. Now, the primary driver behind this disease might catch you off guard. Type 2 diabetes makes up a massive 30 to 50% of all cases. This is a classic intrinsic cause where those tiny vessels, including the glomerulus, become hardened. It's a condition called nephrosclerosis. Hypertension is the second most common cause. Contrast that with type 1 diabetes, which only accounts for about 4%. Other causes run the gamut from chronic heart failure to polycystic kidney disease and recurrent renal stones.
So how do doctors actually measure this decline in real life? They use the glomerular filtration rate, or GFR. It's essentially a measure of exactly how well the kidneys are functioning by showing the flow rate of filtrate through that glomerulus we talked about earlier. Without a doubt, this is the single most vital metric for tracking kidney health.
Using the GFR, doctors map CKD onto 5 distinct stages. Now, here is a tricky part. While stages 1 and 2 might actually have a GFR above 60 milliliters per minute, they are still classified as CKD because there's already physical evidence of kidney damage. As the GFR drops, the stages relentlessly progress, ultimately leading to stage 5. A GFR below 15 marks end-stage renal disease, meaning the kidneys have essentially just stopped working, and the patient now requires renal replacement therapy, like dialysis or a transplant.
Let's shift gears to section 4, the systemic domino effect.
You might naturally think kidney failure just means a problem with making urine, right? But when the kidneys fail, it triggers a literal total body crisis. Initially, CKD is often totally asymptomatic, but as it progresses, the systemic fallout is super alarming.
cardiovascular risk skyrockets. These patients are 5 to 10 times more likely to die from cardiovascular disease than from end-stage renal disease itself. Because the kidneys can't excrete sodium properly anymore, patients suffer from fluid overload, leading to severe edema. They develop anemia because the failing kidneys just stop producing enough erythropoietin, which is the hormone that stimulates red blood cell development. We also see metabolic acidosis and hyperkalemia, which is a really dangerous buildup of potassium in the blood.
And this domino effect goes deep, literally right down to your bones. Here's how. Reduced kidney function means the body produces less of an enzyme needed to activate vitamin D. That directly leads to low calcium levels in your blood. To compensate for that, the body cranks out higher parathyroid hormone levels, which ultimately ends up pulling calcium straight from your skeleton, leading to abnormal bone remodeling and worsening osteoporosis. It's a fascinating, albeit completely destructive, chain reaction.
Next up, Section 5, Diagnosis and Detection.
With all that systemic damage quietly occurring, how does medicine officially catch it? Well, doctors rely on a very strict set of diagnostic tools. According to the guidelines, patients are tested 3 times over a 3-month period. They look at the estimated GFR and creatinine clearance. They also check the albumin to creatinine ratio. That's a crucial measurement of protein leaking into the urine, which is a massive red flag for glomerular damage. But beyond blood and urine, imaging plays a huge role. An ultrasound can spot physical signs of chronic disease versus just an acute injury, specifically revealing things like smaller kidneys, reduced cortical thickness, and increased echogenicity, which basically means the kidneys appear brighter and denser on the scan because of all the internal scarring.
And finally, Section 6, Fighting Back, Treatments. Okay, so we understand the anatomy, the failure, the systemic crisis, and the detection. How do we actually manage these complications and slow this progression down? The foundation of treatment always starts with lifestyle modifications, stopping smoking, managing weight, and adopting a strict low-salt and low-protein diet. Medically speaking, the first-line defenses are ACE inhibitors or angiotensin receptor blockers. These meds are fantastic because they actually widen the exit vessels of the kidneys, physically reducing the pressure inside the glomerulus and slowing down that nephron damage. SGLT2 inhibitors like dapagliflozin are also now considered first-line for dramatically improving mortality, and statins are usually initiated to tackle that massive cardiovascular risk we discussed earlier.
Now here is a highly specific, kind of surprising medical nuance regarding treating the anemia caused by CKD. While doctors do use iron supplementation and synthetic erythropoietin to boost red blood cells, they target a very specific hemoglobin range, 90 to 120 milligrams per deciliter. Naturally, you might think, hey, more hemoglobin is better, right? Actually, no. Pushing those hemoglobin values higher than 120 can actually reduce patient survival. It's a highly delicate, intensely monitored balance.
So the absolutely crucial point is, what happens when these conservative treatments just aren't cutting it anymore? When the kidneys enter end-stage failure, doctors use the AEIOU mnemonic to remember the precise indications for renal replacement therapy, like hemodialysis or a transplant. A stands for severe acidosis. E is for dangerous electrolyte imbalances, like sky-high potassium. I is for intoxication from drugs. O is for severe fluid overload. And U is for uremic symptoms, like lethargy or encephalopathy caused by a buildup of urea. When these hit, a machine literally has to step in and take over the work those tiny nephrons can no longer do.
Wow. We have journeyed all the way from the microscopic glomerulus to the life-saving machines of dialysis. The kidneys are incredibly complex, vital, and, as we've seen, vulnerable to systemic issues, particularly high blood sugar and high blood pressure. Remember, progression can very often be slowed down by managing those modifiable risk factors. So, I want to leave you with this question to reflect on today. Knowing what you know now, how are you protecting your body's ultimate filtration system? Thanks so much for joining me for this explainer, and keep learning.